Thanks so much, Kathy and Victoria, for inviting me to be here. I'm thrilled to talk to you this morning about some of the work that we've been doing with longitudinal deployments of these mobile health technologies. And when Kathy first approached me, she said, we want to do something on engagement. And I said, well, we've been trying to deploy these technologies for many months, over a year. And so what I'm hoping to do today is just give you a sense of what engagement looks like over extended periods of time and how to make sense of that and what we might be able to do it. And so as most of you know, even though our mobile health tools have greatly improved and are getting more sophisticated by the year, the engagement with these tools remains a stubborn problem, right? People use them for a short period of time and then disengage. And many papers have been written about this, but what I want to do today is give you a sense of what that looks at a little bit more granular level and how engagement changes over time for at least in the example of this one intervention that we've been deploying, and then give you a sense of what kind of factors might be driving those changes in engagement. And so the work that I'm going to be presenting today was part of a study that was funded by NCI as part of their intensive longitudinal data network call for proposals. And we got one of the UO1s, Billy Nakumshani has had another one. But so this was based at, and we're calling this study the HeartSteps 2 study because they deployed this HeartSteps system that my collaborators and I have been developing for close to 10 years at this point. I was an MPI with Donna Sprouts-Metz and Ben Merlin, and then we were collaborating with Eric Keckler, Misha Pavel, and Danny Rivera, as well as some wonderful PhD students, including Stephen De La Torre, Mohamed Al-Mistri, and Catherine Tang. And so a lot of this data that I'll be showing you was really sort of attempts to make sense of intensive longitudinal data and to give you a sense of how all of that works. So this particular study was really intended to collect really dense data over extended period of time so we can work on different kinds of modeling techniques. And in particular, Ben Marlin is a machine learning expert, and he was trying to introduce some of the novel Bayesian methods for making sense of longitudinal data. Daniel Rivera is a chemical engineer who uses dynamical systems modeling, and so we were developing some of the models on that side as well. But we were doing this in the context of this physical activity intervention called HeartSteps that we were deploying with a set of overweight and obese adults in the LA County over a course of a year. And in particular, this was not an efficacy or an effectiveness trial. It was set up as an optimization trial where we micro-randomized the number of the components. I'll be coming to that in a second. But mostly, it was really focused on trying to collect longitudinal data so we can develop better modeling techniques. HeartSteps itself consists of two main components. We were using a Fitbit Versa watch to collect physical activity and data, and then a HeartSteps application which was running on Android and iPhone systems. And the HeartSteps application contains basically two classes of interventions. We had a number of what we were referring to as push interventions, which were basically are sent using decision rules in the system itself, that included walk-in suggestions that were controlled by a reinforcement learning algorithm that Susan Murphy developed, that were asking people to basically, we were trying to send them at opportune times when people might be able to go for a short walk over the course of the day. We had anti-sedentary suggestions, which were trying to disrupt extended periods of sitting. And these were they were optimized using an online algorithm that was trying to predict how much more sitting a person is going to do over the course of the day. So to pepper these kinds of things over the course of the day so we don't bombard people with interventions in a short period of time. We had weekly adaptive goals that would help people set feasible but challenging minutes of MVPA goals over the course of the week, as well as a weekly planning intervention where we prompted people to make specific plans about when, where, and how they're going to be active over the following week. And then we had this little motivational message that would show as part of the morning survey that was micro-randomized based on what kind of framing we were using for the message and whether people would get it or not. And then there were a number of pull interventions that included feedback and goal progress, ad hoc planning, as well as self-monitoring feedback, sort of standard stuff that you would expect. Now, this was really the sort of the meat and potatoes of the study. We really wanted to collect data over the different time scales. So we had minute level data for steps and heart rate and minutes of sedentary time. We had daily level data that included some self-report measures as well as active minutes and the logs from the system. And then we had weekly measures, again, including some self-report measures and barriers of facilitated to PA. We had these periodic, relatively intense EMA bursts that happened every 3 months, and then, of course, a bunch of baseline measures themselves. This was a single-arm study, so that micro-randomized walking suggestions, anti-sedentary suggestions, and morning messages. And again, this was sort of overweight and obese population in the LA County, and we deployed this over the course of a year. Everything was done remotely because we were doing this during COVID. And really the main thing that we asked of participants is just to wear the Fitbit, right? So the main request here is to just wear the Fitbit for at least 10 hours a day. And that's the only really adherence monitoring that we did because we wanted at least a very minimal set of physical activity data as the base. Everything else was really mostly based on how helpful people found the intervention and whether they wanted to use it or not. So really what we were trying to capture is what naturalistic use of this intervention looks like over a course of a year. So what did we find? Well, so what I want to do in the next little while is really focus on these trajectories of both engagement and activity to give you a sense of how this kind of data unfolds over time. And in particular, I'll be focusing on a set of weekly measures that we sort of rolled up from the daily level, and that include morning survey completion, the number of page views per day, the number of messages received over the course of a day, and this is all averaged at the weekly level, and then activity metrics for the Fitbit hours worn and the step counts. And you can sort of think of these as being a combination of adherence and engagement measures for some of these, so the completion of surveys and paid reviews and so on, as well as activity in terms of steps. The data itself comes from 86 participants, 40% of whom were Latino, and we censored the data at 42 weeks because that was the cleanest data set for all of the participants, and we aligned everyone to the first day of the study. So with everything that you're going to be seeing coming up, basically you can tell every participant is starting at sort of day one of their participant enrollment, and so everything is sort of centered on the duration of their study involvement. And so just to start, the first thing that I want to show you is just what this looks like if you just do standard spaghetti graphs, right? And what you see here is that it's a mess, right? It's very hard to make sense of this. However, the main thing to take from this is that you can see even from this simple graph across these various metrics is that there's a tremendous amount of heterogeneity, right? I mean, so there are lines everywhere, right? And so the question becomes, can we make sense of this and dig into this a little bit deeper, right? So the very first thing that we can do is just try to provide some summary of this. And in this particular case, what you're seeing now is the median for each one of these graphs, as well as 5th percentile, 25th percentile, 75th percentile, and 95th percentile data. And this already starts giving you a little bit sense of what is going on. What we're seeing here is that at least at the level of the whole sample, people on average would respond to these morning surveys every couple of days, right? So basically 0.5 in this particular case means that they were that averaging over the course of the week, every other day, they would respond to a survey. You also see that across most of these measures, there is at least some reduction in intensity of the measure over the course of time, right? So app page views go down, the number of messages received go down, and I'll be coming back to that, why that might be the case. And then one of the things that I think is probably most striking about this graph is that if you look at the planning, which is the square in the bottom left here, there's a little bit of planning at the start, but then if you look at the average, people just don't plan anymore, right? And so this gets lost. And so at the level of a whole sample, it seems like there's slight reduction, but really, it's really hard to tell what's going on here because there is so much heterogeneity within this. And so what I'm hoping to do over the next few minutes is try to unpack this a little bit and give you a sense of what is actually happening with this data. So first, let's start with just trying to see how is this data correlated in the context of the whole sample, right? And so what Ben did with this is he used this metric called total correlation, which you can think of it as a correlation that has both a within subject and between subject component. component, right? That allows us to, at least at a very broad level, see within individual people, if you summarize that over the course of the whole sample, how is this, what are there certain data types that are connected to each other, right? And so one of the things that you would see and we might expect is that engagement measures tend to co-vary, right? So in this particular case, the number of page views is also correlated with the number of hours of Fitbit wear, right? So people who are adherent tend to be pretty adherent across most of the things that you ask them to do, right? So that's not particularly surprising. It's also not particularly surprising that to some extent you see a little bit of connection between adherence or engagement and the actual activity, right? So when people use the intervention more, they tend to be more active, and we see that here because both for the morning survey completion and app page views, there's some moderate correlation with Fitbit steps, right? And you also see that insofar as actually for individual intervention components like planning, that you get a little bit of impact on physical activity as well. So we have a moderate correlation between engaging in planning and physical activity, right? But again, all of this is still at the level of just trying to understand just the sample as a whole. But really what we want to do is understand individual people. And so to do that, we need to go back to looking at individual trajectories themselves. And another way of doing that is via these heat maps, right? That we look at. And in this particular case, just because there are going to be a lot of graphs like this, let me just explain what is happening here. The x-axis here is time, and so every little block of this graph is 1 week of study participation, right? The y-axis are participants, where you have basically one tick for every participant, every of the 82 participants that are in this sample, and then the color of the square corresponds to the intensity of that particular measure, right? Going from black, where basically level of 0, to bright yellow, which is whatever is the highest intensity for that particular metric, right? So in this particular case, for morning survey completion, that only goes from 0 to 1, right? Where 1 is that someone completed the survey every day, 0 is that they did not complete the survey at all during that week. And so each square is basically 1 person week of data for that particular metric, okay? So we can do this with pretty much every one of these metrics that I was just showing you. But the interesting thing is trying to figure out now, can you actually group people together? And for this, we use something called hierarchical agglomerative clustering, which is basically an unsupervised machine learning method to cluster the trajectory data, right? And what you see here is that basically the clustering algorithm tries to group people together whose trajectories look kind of the same, right? And so for this particular case, for the morning survey data, what you get is that we have some people. Just turn this thing on. And at the top, who are pretty responsive, right? Who seem to be responding to morning surveys pretty much over the course of the whole week. You got a whole bunch of people who responded once, a couple of times during the first week and then never responded again. You have people who are sort of intermittently responsive. Sometimes they respond, sometimes they don't. And then you have a whole lot of people who are to some extent responsive throughout the whole study, right? So a lot of variation in how, what their response patterns look like. And we see that across a number of other metrics as well, right? So for app page views, similar kind of situation. Some people are using the app a lot, right? We have a bunch of people who are not using it at all past the first week. We have some people who started using it for a period of time and then dropped out completely. And then we have people who are sort of using it for a while, they stop, they use it for a while, they stop, and that at various rates, right? So here it's at a week or two at the time. Here it's sort of this person used the system for a few weeks, then didn't use it for, well, what does that look like? A month and a half, used it for a little while, didn't use it for another month and a half, and so on, right? And the same kind of thing which you see, which is pretty interesting for messages received. So again, the number of messages that people received was actually driven by a reinforcement learning algorithm, right? And so people who were responsive to these messages ended up getting more of them. People who were not responsive ended up getting fewer messages. And that's exactly what you see, right? Some people were not responsive. In this particular case, they probably uninstalled the app because we're not getting any data at all, right? But for a lot of people, there were sort of the the number of messages they're getting sort of varies from week to week. So sometimes they get more, sometimes they get fewer. And what you see with these vertical lines of bright yellow, this corresponds to really these EMA bursts that we did, where everyone was being sent a whole bunch of EMA surveys for a week every 3 months or so, right? Here's where I think things get a little bit more interesting, right? So what you see here is on the left side is the data for planning, right? And this is, so planning, again, what we ask people to do is, the only requirement for planning was as part of this weekly intervention that was sort of a weekly reflection on the previous week's data, where we asked them to make some plans for the following week. But then people could also plan ad hoc, right? They could go into a planning module at any point and plan. And so what we're showing here is the number of planned activities per day, average over the course of a week for each person, right? And what we see is that a lot of people are just not planners at all, right? No planning at all. We have some people who plan a lot, right? And then we have some people who really sort of start planning, plan for a while, and then drop out. Other people who are sort of inconsistently planning over the course of the whole intervention. But you're starting to see really quite a bit of difference, given that most of this is really sort of discretionary use of this one intervention component. We're starting to see that sort of to what extent people actually find this component useful varies a whole lot across people. And you can sort of think of yourselves and your family members and friends. Some of us are planners, others are not, right? And what we see that in the data here. The number of Fitbit hours worn is also pretty interesting, because we got quite a bit of high level of wear, right? At least it looks like about a quarter of the sample wore the Fitbit at least 10 hours a day all the time, right? And in this case, it went up to 16 hours a day. So a lot of these people were wearing Fitbit pretty much all during the whole waking hours. A lot of other people were wearing it for a period of time, and anywhere between 6 and 12 hours, with only a few gaps over the course of the study, right? And then you had some people who just basically dropped out relatively quickly, and others who were starting to drop out halfway through the study, right? What is interesting here is that some of them come back, right? So you see these clusters of people who were gone for a period of time, and they come back. And again, and then of course, what we get with Fitbit step counts is something that is relatively correlated with that, right? So people who wear Fitbit a lot also tend to we're able to record more steps for them. So we get some people who are really active, other people for whom we have data when they're wearing the Fitbit, but then the data goes away and so on. What this allows us to do, though, and which is what I think is pretty interesting, is to actually start developing digital phenotypes of this data, right? And so you can take these clusters, and you can actually look at the sort of the median and quartile information for them. And so even for something like morning survey completion, you see some very distinct patterns of what this data looks like. You have people who are high and steady, right, who are always answering the surveys. You have people who sort of start relatively slowly, but then increase, but then become more variable over time. You have people who stay relatively low over the course of the whole study with some variability. People who start high and then just sort of drop off over the course of the study. And we can pull all of that out through this sort of unclustered data in these longitudinal trajectories. The other thing that we can do with this is then start to look at how different digital phenotypes correspond to other kinds of data. So the first column here is the data on the survey completion that you were just seeing, and then the other two columns correspond to Fitbit hours worn and Fitbit step counts. And what you see is some correlation among these things. So people who respond to surveys a lot, so the very top, also tend to be pretty good about wearing their Fitbit, and they have a sort of reasonably steady step counts over the course of the whole study. People who are more variable also tend to have a little bit more variability about the Fitbit wear time, and that is reflected in the steps as well, right? So we can start actually seeing how groups of people co-vary on the various measures that we collect on them. And this is, I think, one interesting way to see that visually, right? The other thing, of course, that we can do is start to look at like to what extent these kinds of measures correlate with different kinds of baseline characteristics. And what is interesting here is that we're basically getting next to nothing, right? So if you look at the actual sort of correlations between different types of data longitudinally, you get substantially higher correlations than what we get for baseline characteristics. So the only thing that we have, for whichever reason, is that people who are middle-aged or higher seem to be more of a planners than younger people. So we get a little bit of this moderate correlation for middle age and planning, but by and large, the rest of the stuff just doesn't seem to show us much of anything, right? So to summarize this data, right? So one of them is that really trajectories are highly variable. There's a lot of variability in this data, and pretty much all of this variability would be lost if you were just doing pre-post assessments, right? The other one is that the really people's data covary meaningfully. So people who tend to be adherent to one aspect of the intervention use tend to be adherent to other aspects of intervention use as well. And what was surprising to us is that we really can't, at least in our data, we couldn't make much sense of this using baseline characteristics, things like psychosocial constructs or demographics, right? They were not really indicative of how people would behave in this intervention. So the question becomes then, so what is actually driving this variability, right? And the short answer to that is that shit happens, right? People's lives are complicated, and that various things that happen in people's lives really drastically impact their ability to participate in interventions or even pay attention to health behavior like physical activity, right? So one key thing that kept popping up time and time again is really health status. In this particular case, we had a participant who got diagnosed with depression and anxiety during the study. She was doing really well up to that point, and that just sort of dropped out. We had people who would get injured, and then so they would stop using the system, and they would not recover after injury. We had some people who got injured or sick, like this again, COVID time. So we had a number of participants who got COVID, who actually would then go on for a number of months and then came back into the intervention. So these kinds of things end up making a big difference to people's ability to participate, right? Other kinds of the disruptions and obligations, right? So in this particular case, we had a person whose mother passed away, and she said, after that everything fell apart. But we also had people, participants who changed jobs, who ended up moving to night shifts and things of that sort. And they talked to us of saying that basically, that these changes often created enough stresses in their lives where they couldn't really focus on using this intervention over time, right? Or the need to prioritize other parts of their lives. So here's one participant whose father became really sick and needing long-term care, and so he was just staying with his dad in the house and was not able to exercise, right? And so at that point, all of these intervention components that we're using to encourage physical activity become annoying, right? Like if I'm sending you a goal every week on minutes of MPPA and you're not able to get to leave the house, the intervention not only stops being helpful, but it actually becomes frustrating, right? And the other thing is that we're finding also is that various intervention components really do work differently for different people. They don't work equally well for everyone. And so planning is a prime example of this, where some people just did not find planning useful at all. And just they tried it and they stopped planning, right? And then this both had to do with people who had routines, right? So someone who is going for a walk after work every day does not need to plan that. Like there's no point in planning something that you do the same way every time, right? Other people just don't like planning as an activity and don't plan, right? And so there is a lot of variation with how much people use intervention components. Most of the time, we don't adapt for that, right? We give the same thing to everyone, and we ask everyone to do the same thing. So there's very little sort of ability to adjust these interventions to what people actually need. And we hear that from our participants time and time again. Right? And so what can we do differently about all of this stuff? So I'm going to give you a set of sort of approaches that we have been taking to try to deal with this variation in engagement. And I would love to hear, I'm going to leave a fair bit of time for discussion, so I'd love to hear if you guys have other ideas. But the main thing that we're currently focusing on with the new R1 project that Brahmaji and Jesse Golbus and Mark Newman are on is really to think about how we make these kinds of systems more adaptive. So that the kinds of things that you were just hearing about, these kinds of disruptions in people's lives, illnesses, differential perceptions of helpfulness of different interventions can really be accounted for. And so we're trying to do that through a couple of different ways. One is we're actually building in interfaces in terms of UX interfaces within the interventions that people can use to make changes to the intervention or to provide feedback to them, right? So the idea is to basically be able to, if I send you a prompt to plan and you don't find planning helpful, you should be able to tell the intervention, this is not helpful to me, don't do it again. Or if we're sending you certain kind of interventions too often, right? So we're sending you a reminder to get up too often, and it's starting to annoy you, you can say, dial down the frequency of this, right? That's one type of thing. The other thing that we're trying to do with this project is really think about what is the global changes to the intervention functioning that we might be able to support. And so if someone gets the flu in the context of physical activity, they're going to be out for a week, right? I mean, they're just not going to exercise. And so part of what we want to do is to be able for the system to the person to tell the system, just turn everything off for the next week, right? I mean, I'm just going to pause the system, or just send me an occasional motivational message to say that things will be okay once you come back. But you really shouldn't be sending people goals. You should not be sending them planning prompts. You should not be doing all of the stuff that we typically use to support activity, right? The other thing that we're doing is trying to actually incorporate this user feedback with the reinforcement learning algorithm. So this is the work that Susan Murphy is going to be heading, where we can basically have feedback mechanisms within individual interventions. So if I send you a walking suggestion, and the timing is just inappropriate, right? It's a busy time of the day. You should be able to say, this time doesn't work for me. And the algorithm should be able to pick that piece of information and incorporate into its model for this particular person to reduce the frequency of providing that intervention during those time periods, right? So closing this loop between reinforcement learning algorithm and human feedback to make the system more adaptive in a way that really works for people. And the other thing is that if someone has actually turned something off, let's say I've turned off planning and that planning doesn't seem to work for me, figuring out what are the right ways of checking in with the person to seeing whether something changed and whether the policy needs to change again, right? So if the person's activity is fine for a period of time, we don't need to bother them, right? They're sort of in a maintenance state, and we can just reduce the frequency of things that are happening and the intensity of support. But if we see that their activity is starting to drop, at some point the system can check in with the person and say, do you need more support, right? Or we know that you said that you don't like planning, but there's good data that shows that planning can be helpful. Can we turn it back on for you for a couple of weeks and just see whether this works for you now, right? And so really trying to make the system act in a much more in a way that a sort of a human coach would, where it's responsive to the person's needs and it changes what it does based on how the person's circumstances and needs are evolving over time. So that's one piece. The second piece that we're doing is trying to really think about how can we provide behavioral interventions that can support internalization of motivation so that people can bridge more effectively these gaps that inevitably happens with any of these health behaviors, right? So we understand that by and large, most of the health behaviors that we try to support are sort of priority number 5 or number 7 for people. Sometimes not even that high, right? But one way of dealing with that is to try to see, can we actually change these things like physical activity from being another chore, another to-do list for people to something that they actually feel good about and want to do, right? And so one of the things that we're doing is trying to really support intrinsic motivation. So this is the work by this Ph.D. student Sue Choi that works with Mark Newman and me, who is developing this system called Walk to Joy, which is intended to help people learn to enjoy physical activity more. And so we have the kinds of interventions that basically just pair physical activity content with just smile-inducing GIFs, right? I mean, and this is basic classical conditioning where we send them little GIFs with messages, and the GIFs are supposed to just make you smile. And most of you, when the slide went up, smiled, right? And so the idea is that over time, this will start to changing the people's gut reactions, these affective evaluations for physical activity towards a more positive end of the spectrum. We're also trying to make people a little bit more aware care about just the intrinsically positive aspects of being active. So feeling less stiff, feeling a little bit less stressed, having more energy. That often is just not salient enough for most people to really allow for that belief updating that is needed to change the affective evaluations and attitudes. And then in the work that Sue is doing now, trying to figure out how do we tie that to identity structures. And because one of the things that we find, and even we see in the data that we collected, is people who think of themselves as active, right, will resume activity even if they have had long periods of time of inactivity that was due to illness or injury, right? So if you think of yourself as a runner or a cyclist, or and you break your leg, right, and you're out for 6 months. When you come back, you start exercising again, right? It's not a question. And what's driving that is really this dissonance between how you see yourself as a person and the activity that you're doing, or in this particular case, not doing. Right. And finally, Stephen Della Torre, who is a Ph.D. student on this project, and is going to be joining us actually here at Michigan in the spring as a postdoc, is really interested in co-designing these interventions for both families and communities in a really culturally adapted way, so that we can use the assets that are already present within families and within communities to support health behaviors in a much more sort of genuine way, where this is not feeling like something that each person is doing separately, but to try to integrate these things into the practices that are already going on. And he's particularly focused on the Latino communities, where really both people live in multi-generational households a lot more, as well as the larger family gatherings are much more the norm, and is interested in thinking about how can we leverage this into to support physical activity in a way that feels very different, right? And than a lot of these individual-based interventions that we have been typically developing so far. And so the idea here is to really try to make things, co-design these systems with the communities and with families, to allow them to much better integrate into their lived experience. And I know that many of you are working on similar kinds of projects here as well. So I'm going to stop there so we have time for discussion. Thank you so much for your attention. I'd love to hear what you think. Yeah, Libby. Thank you so much, Pedja. That was amazing. Can people hear me? Yeah, you're good.
And there's a mic right over there. Yeah.
I thought that was fantastic, and I loved all the data visualization, super cool. And I agree with you that there's so much potential for personalizing these interventions to keep people engaged and to be more helpful. But I'm wondering how you think through some of the analytic considerations when you're allowing for these different personalized components, like allowing people to pause the intervention or things like that.
Yeah. So, I mean, depending on analytical considerations for what, right? If you're actually doing a confirmatory trial, an effectiveness or efficacy trial, really the way I think about this is that the thing that is being tested is protocolized, including some of these abilities to make changes. And so it's really that protocolized adaptive intervention that's being evaluated. People are going to use that intervention differently, right? Some people will turn off planning, other people will not want goals, or whatever might be the case. But what you're evaluating is the system that has the ability to be personalized in such a way. And as long as that is protocolized up front, and that you're not changing intervention halfway through the trial, things should be okay, right? I mean, the other thing is to try to understand why people actually do these things within the system, right? And that, I think that's where things get a little bit trickier, because a lot of these things, as you were seeing from some of the quotes, are really not the kinds of things that we would normally ask about. Like, you don't ask people every day, did your mom die? Right? I mean, because it just doesn't make any sense. But sometimes, if you have a large enough group of people, someone's family member will in fact pass away, right? Or someone will get sick, right? And so it's often the case that the kinds of things that you want to capture to really understand deeply what is happening is not things that we can do through standard protocolized EMA assessments or surveys, just because they're relatively rare events at the level of a single person, right? So it doesn't make sense to ask about them time and time again. But with a large enough population of people, they're going to happen, right? And so one of the things might be to provide an easy way to annotate these decisions. So if someone actually does does something within the system and say, okay, don't, turn off the planning, that there is a relatively easy way to just say, why did you do this? Like, yes, of course, we're turning it off for you right now. Can you just, in a couple of words, let us know why this happened, right? There's going to be some, of course, then coding that needs to happen to try to turn that into structured data you can analyze. But I think really trying to do this a little bit more as a part of the experience of the intervention rather than as a research assessment is probably likely to produce better quality data, right? And so that's one of the things that we're finding. And when we talk to people about these EMA assessments that all of us do in the context of EMA of mobile health studies, the single biggest thing that people complain about is that we ask them these things time and time again, and we don't do anything with that data. Like the system does not change based on what they tell us. Like if I ask someone in the morning, how busy is your day going to be today, right? And they tell me it's going to be really busy, and I still send them 7 notifications that day. Like it's just a terrible user experience, right? It's one thing doing that when you don't know anything about the person, but they just told you it's going to be a busy day, and you still bother them, right? And so the biggest thing that we're hearing in terms of the need for adaptation is for the data that they're providing to actually be used in a way that helps them have a better experience with intervention, right? And so if you ask for a little bit of annotation and you make the change that the person wants to make, then that's a very different experience than what we currently have. Hi.
I have several questions, and I wish I had a whole day to spend with you because my whole life is spent around trying to keep people engaged in an intervention. So have you considered behavioral economics and disincentives as opposed to providing a whole host of incentives? In the short term, I think incentivizing people in a positive way may work. Any of these novel things, that are considered sexy work acutely. It's what, they don't persist. There's no persistence. And when you take something away, that has greater salience. So I'm just wondering how that fits in all of this.
So we don't actually provide incentives for these kinds of studies. So we will incentivize people for completing like the baseline survey and the interviews, but we don't incentivize intervention use. And part of the reason for that is that we want to understand people's naturalistic use of these systems. So providing incentives for intervention use changes that completely, right? And as you said, there's a fair bit of data showing that certainly in this case of smoking cessation and weight loss, that if you have an incentive-based intervention and you remove the incentive, you get recidivism, right? So I think external incentives have not been something that we have used much. In the context of Walk to Joy, right, and other work in that family of projects that we're working on currently, the incentives are really internal incentives, right? So it's really enjoyment. It's the feeling better. It's the sort of this salience of how this fits with you as a person and who you're trying to be, right? Those incentives don't quite go away. Right, and we see that with again identity as a prime example that people who have managed to connect physical activity to how they see themselves as a person, right? That tends to be a lot more robust and to have a lot more sort of staying power, right? And so so in terms of the incentives, that's the direction we have been going, is to really try to make the incentives come from the person themselves, right, rather than from the outside. But I'd be curious to think about when you think about disincentives, what kind of things are you thinking about?
Well, I'll just give you. This is not applicable to what you just talked about. But for example, when insurance covers a certain intervention and there's no copay and the cost of drugs is less, if the participant ends his or her participation, they are going to end up, and they understand this a priority, that they're going to have to pay for these. And that really has salience. I mean, for long-term engagement. I'm not saying let's be punitive, but I'm just saying I think we need to think about, we give people a lot, suites of services and a lot of choices, and maybe what we should be doing is saying, look, if you don't do this, this is what's going to occur.
So, I mean, we do know from behavioral economics that people are more sensitive to losses than to gains. And so one place where we try to play through this was these morning messages that we were displaying as part of the intervention, which so this was done in collaboration with Alex Rothman, who studied framing for decades at this point, where we basically had some of the messages that were really focused on gains of being physically active or not being sedentary, and then other messages that were focused on losses if you're not active or if you are sedentary. And what we see is that at least in the context of this kind of intervention, those small changes in framing over time just wash out. And my sense that the reason that they wash out is because after a while, people are really not reading these things very carefully, right? It just becomes a prompt, right? That it's more of just a reminder than anything else. Like, oh, okay, yeah, you're talking to me about activity, but they're not engaged sufficiently cognitively for that effect to at least with the subtle variations that we can be doing to last for a year, right? A larger loss, if you could actually manipulate larger losses in an ethical way, that might be different. But certainly in terms of framing of some of these messages that we often use with these kinds of interventions, I'm not sure how much that lasts, partly because there's habituation is the main enemy with any of these messaging-based interventions, and people just stop paying attention.
I have a question.
Go for it.
I'm a complete novice in this area. So how do you assess for like a person's ability and capacity for habit formation in this process? Because I feel like there's some people that it's not going to be based on any of the prompts in general. It's just an inherent ability to form and adhere habits. Is there a way to assess for that in your work?
Yeah, so why would you want to assess, right? I mean, partly you would want to assess if you want to be able to tailor interventions or adapt them to more habit formation strategies versus not, right? I'm not sure that I certainly haven't done any work where we try to assess that upfront. What the sort of an easier way to do it from the perspective of how we have been doing things is to really use reinforcement learning across different classes of interventions. And basically, if a, let's say, habit formation prompts asking people to anchor activity to another thing that they're doing on a daily basis or something like that, if they're not responsive to that, you just turn those prompts off. And if people are responsive to it, you might actually be able to then try to increase the likelihood of other interventions of the same sort, right, within the same category being provided. My sense is that a lot of that, at least in the context of physical activity, varies a great deal for a lot of people, both seasonally and in terms of how their work or school schedules change, right? So what we saw with this study is that during summers, there was just a lot more stability in people's behavior than when September came, right? And partly it's because even though it was not just a youth sample, a young sample, people have kids, right? And they go back to school and their schedules get all messed up, right? So when we look at the sort of stability of the data on the intraday level, right? Within the summers, there was a fair bit of sort of stability that you could characterize as habit. People going for walks at the same times every day, right? Things of that sort. The September comes and it all falls apart, right? And then you might actually want to switch to something that is more planning based or sort of more opportunistic based than habit formation, right? And so my sense is that people themselves have reasonable good sense of whether they can incorporate physical activity into a habitual pattern or not, right? And so maybe not necessarily trying to assess it, but trying to provide options and seeing which ones work for them is probably the way I would approach it. Although, I mean, I'm sure there are other people here who have worked on this. That maybe David, do you know of anything that on assessment of habit formation as a? I mean,
there's some report measures of automaticity that you use.
Yeah. That's exactly right. Yeah.
We've shown that decreases activity among people with strong habits already.
Yep. Yeah. Go for it.
Thank you. All right, it's a really great talk. I was curious, when you were talking about adapting interventions based on sort of the context, what's going on for people, I was wondering how you think about doing that from like the platform side, when you were showing the trajectories, I was thinking that where you might be going was that when someone's on a trajectory of maybe disengagement, thinking about telling them, hey, we noticed you're not really digging this. We're going to give you a pause. And if you don't want that, let us know, as opposed to having people opt into pauses, and how you might balance those, or which you might have to take the lead.
So, no, really good question. A couple of things that we're trying to do. One is to have some relatively small number of overarching policies that correspond to sort of, you can think of it as stable, broadly stable states for a person, right? So times when they need a lot of support, whether they're initiating activity or because they fell off of the wagon and they're trying to get back on, right? The system would work differently in that kind of state than if someone is just sort of coasting and doing fine for a period of time. Like in the case of our participants, summertime, they're getting plenty of activity. We might not need to bother them very much, and you might actually want to change the overarching policy for the whole system to that. And then if someone needs to take a break, right, you would have a break policy that might just provide an occasional motivational message saying, everyone ends up needing time off. You can always get back when you're ready, or something of that sort, right? But in terms of actually whether you prompt changes to the intervention or the person sort of does it themselves, the best that we've been able to figure out on that front right now is that really people don't dig into settings to change this proactively, right? And so what we want to do is provide them ways of making these changes in reaction to something the system does, right? So if I send you a weekly activity goal and you had just gotten sick, that's the time, like if they engage with the goal, that's the time to actually for you to say, leave me alone for a couple of weeks, right? I mean, I'm sick and I'm not going to do this goal, or don't send me a goal next week, right? Something of that sort, right? And we're trying to figure out, so really this project is about trying to figure out the user interactions that allow that to both be effective in terms of informational for the system to be able to do the right thing, as well as something people would actually be willing to engage in, right? So that's one piece. But there are certain kinds of things that you can do based on just looking at people's activity, right? So again, in your example, if someone, if their activity is dropping for a period of time, right? You can either say, we've noticed that things have changed, your activity is dropping. Do you either need to take a break, or do you need actually more support, right? And then you can have them opt out for that. But my sense is that the granularity at which you're going to be able to do that is relatively coarse, right? So it might be that you need to actually look at a 2 or 3 weeks of data before you actually can with reasonable accuracy say something has changed here substantially over just the variation that we see in people's data all the time, right? Where you would want to prompt them explicitly about making a change to the policy. Hey, okay.
So I have a question about how to balance the need to learn and the respect patient's choice. For example, I don't want to receive any walking message if it's like cold outside for 2 weeks. So say many of us don't want to do that. Say that's for a particular region, then you will not have like
any learning.
Diversity of the actions in those weeks. So clearly you're respecting very much my desire not to walk in cold weather, but how does that affect the ability for the algorithm to learn? And more broadly, like I'm not going to complete pause it, but I'm going to lower the frequency of say walking message. And how does that factor into the learning piece? So I mean, really good question. And I think you partly answered it, right? So one way to do this is to basically just say when someone wants to turn something off, what you really do is just tell them, we understand that you don't want this. We will really drastically reduce the frequency of these things, but we'll just keep a couple here and there, so just in case you change your mind, right? And so then you shift down the probability to, I don't know, 0.1, 0.05, depending on what intervention you're using, but to still allow for some exploration, right? I think the key thing there is really the messaging around that, and that's part of what we're trying to work on right now with this new grant. Is really how do you actually communicate to a person is that yes, we're going to listen to you and do what you're asking us to do, and at the same time we'll do it in a way where the system can still learn and recover if change if you both in case you change your mind as well as to just continue to learn, right? And so I think my sense is that very rarely would you want to
a completely deterministic policy. And the only times that you might want to do that is really if someone really is sick or injured in the case of physical activity, and they're just not going to be able to do anything, right? There's no point in learning during that period of time, right? It's just you're not learning anything anyway, right? But you might be able to negotiate at that point is when learning happens again, right? So if you say I'm sick, don't bother me. You can say, okay, we'll check in with you in a couple of weeks, right? And then you reintroduce start slowly reintroducing things, and you see how they respond. But I do agree with you that turning things off completely and just leaving them off for forever is probably not the right approach. Both because it doesn't give people themselves an opportunity to re-engage a component if something changes in their lives, because again, they're mostly not proactive. They don't think to say, oh, I've not had any planning in 2 months, but I think it might really benefit me again, so I'm going to go and turn it on. That doesn't happen. So what you want is the system to at least maintain some ability to offer further support that might have not worked in the past, but that might start working again, right? And that does involve maintaining some ability to learn and some basic level of probability on those interventions. All right, thank you so much.